All right, party people, we are back at it with part 3 of this Cardio Pharm series. Let's get it. Jumping into amiloride and tramtarine. These are your potassium diuretics. They inhibit ENaC. These are epithelial sodium channels. These decrease sodium reabsorption distally and prevent water reabsorption because water follows sodium. These drugs also indirectly inhibit sodium TPases. These are transporters on the basolateral membrane of the cortical collecting duct. That gets into deeper physiology, but ultimately, that's why they're considered potassium sparing. Now, the key point is the sodium-potassium ATPase reabsorbs sodium and secretes potassium. If you block ENaC on the apical membrane, you indirectly shut off the sodium-potassium pump. What matters for the exam is knowing that amiloride and tramtarine are ENaC inhibitors. They're potassium sparing, and either one can be used if the patient is already on a loop diuretic and you need to add another diuretic on top of that. This won't drop your potassium too much, and hence why they are used. Next up, we got spironolactone and eplerenone, and they are aldosterone receptor antagonists. Their mechanism also results in decreased sodium reabsorption. They indirectly shut off ENaC on the apical membrane and are also potassium sparing. That's why they can be added after furosemide. You don't want to use 2 diuretics in a row that cause hypokalemia. As for treatment sequence, for heart failure, we're going to hammer this again because you really have to know this. So first we start with ACE inhibitors or ARBs. This is followed by a beta blocker, and then finally spironolactone. You can also use these for aldosteronomas, aka Conn syndrome. If this comes up on the exam, they'll describe it as a patient with low potassium, high bicarb, and high blood pressure. That's the classic high aldosterone triad. Sodium may be normal, even though in textbooks it might say that it's classically increased, but for the exam, it's sometimes normal, so don't let this throw you off. Then they might mention an elevated aldosterone to renin ratio. This rules out renal artery stenosis or fibromuscular dysplasia. That points to the primary adrenal cause like Conn syndrome. This is an aldosterone secreting tumor, and the drug of choice for this syndrome is spironolactone. Spironolactone is anti-androgenic. It can also cause gynecomastia. Eplerenone has a lower risk of gynecomastia and is often preferred over spironolactone. Now, lisinopril is a USMLE favorite. ACE inhibitors are used in pre-diabetic, diabetic, atherosclerotic, and renal disease patients, as well as anyone with proteinuria or elevated creatinine or renin. Now, you might be asking, don't you avoid ACE inhibitors or ARBs in patients with bilateral renal artery stenosis? Yes, you do, but for the overwhelming majority of cases, so for example, if they give you a dude in his 50s with high blood sugar, you give lisinopril. Or on the flip side, if you have an older woman with some proteinuria and normal blood sugar, she still gets an ACE inhibitor like lisinopril. In renal artery stenosis, when you see a patient with high blood pressure plus stroke, TIA, or renal artery occlusion, they want you to give them lisinopril. ACE inhibitors can cause a dry cough. That's because ACE, angiotensin converting enzyme, is also known as bradykinin-ase. So inhibiting this enzyme leads to a bradykinin buildup, which causes vasodilation in the lungs and results in that dry cough that ACE inhibitors are famous for. Now, ACE inhibitors can increase potassium levels, which makes sense. You're decreasing aldosterone synthesis, which results in increased potassium. Angiotensin II normally stimulates aldosterone synthesis, the zona glomerulosa of the adrenal cortex. So blocking that means you retain potassium. Also, you have to know to avoid ACE inhibitors in hereditary angioedema. This sometimes is overemphasized. Students that do not know what angiotensin II does might be tempted to give an ACE inhibitor to someone in hereditary angioedema. This is wrong. You do not do this. This is to be avoided. Moving on to valsartan, a ARB, an angiotensin II receptor blocker. ARBs and ACE inhibitors can be used interchangeably. They have identical use cases, and the key difference is ARBs don't cause a dry cough. If ACE inhibitors and ARBs are listed as separate answer choices, they'll usually both be wrong. The test won't ask you which causes a dry cough because it's too easy. They'll more often give you a case trying to see if you can recognize when an ACE inhibitor should not be used. But if you see them both listed and there's nothing that would indicate one preferentially over the other, then probably they're both wrong. Now, as far as phenylephrine and oxymetazoline, these are alpha-1 agonists. They cause vasoconstriction, increase blood pressure, and can trigger a baroreceptor reflex that decreases your heart rate. That's the physiology connection to cardiology. Clinically speaking, they are used intranasally for nasal congestion. You'll find them in over-the-counter sprays. You can also use them to reduce nasal bleeding. This makes sense because they cause mucosal capillaries to constrict. Be aware of rhinitis medicamentosa. This is rebound nasal congestion after prolonged use of these drugs. Basically, the receptor becomes desensitized, and when you stop using it, extremely nasally congested. The treatment for this is to discontinue that drug, and eventually you will return to normal. As far as isoproterenol, it is similar to dobutamine in the sense that it is a beta-1 agonist. However, it also has beta-2 agonist activity. So it increases heart rate via beta-1. It causes vasodilation in peripheral arteries via beta-2. They'll often present you graph-based questions asking you if you know how this drug acts and on what receptor. And then they'll give you physiologic changes, and you'll have to see which one goes up and what goes down, or what constricts, what dilates, and so forth. Methyldopa and clonidine are alpha-2 agonists. Alpha-2 is a presynaptic negative feedback receptor that decreases norepinephrine release. Methyldopa is classically used in pregnancy for hypertension, along with labetalol and nifedipine. Clonidine, on the other hand, is also used in psychiatry for Tourette's syndrome. As far as hydralazine, this is tested for its physiology. You have to know that it dilates arterioles, not veins. It decreases blood pressure and leads to reflex increase in heart rate. It's used in hypertensive emergency pregnancy and in combination with nitrates for heart failure. That combo, you need to know, decreases mortality. We're going to run over this again because you need to know it. In terms of heart failure treatment hierarchy, first, ACE ARBs, second, beta blockers, then spironolactone, finally, hydralazine plus nitrates. All of these decrease mortality. You have to memorize this list. Now, for nitrates, you do have to know the mechanism. They want you to know that nitrates increase guanylate cyclase. This in turn increases cyclic GMP. This cyclic GMP activates protein kinase G. Protein kinase G leads to a relaxation of vascular smooth muscle in veins, especially. This causes venous pooling. This in turn decreases preload. And finally, this decreased preload relieves the anginal pain that the patient was suffering from. This is why we give nitrates in specifically anginal episodes. They might give you a question like, if they give you a vignette and they say a woman has anginal pain, she takes a pill and slips it under her tongue. What is the mechanism of action of that drug? And your answer is going to be increased cyclic GMP. Do not combine nitrates with phosphodiesterase 5 inhibitors like sildenafil, because those drugs prevent cyclic GMP breakdown. Together, they cause severe hypotension. So again, hydralazine and nitrates together improve mortality in heart failure. You have to know this. So they might give you multiple drugs and you have to pick which ones are useful or improving mortality. Now, if they give you a question like that, if they say, which of these drugs can you add to the patient's regimen to decrease mortality, what they might do is say that the patient's already on hydralazine, and then at which point you would then have to choose isosorbide dinitrate as the correct answer choice. Now, nitrates primarily act on veins, so choose veins for nitrite question. But if it's nitroprusside, you have to know that that actually acts on arterioles, so choose arterioles over veins. All right, that's it for this one. Go crush it.